All right, we got it.
All right, thank you. All right, I will call the meeting of the Public Health and Human Services Board of Tuesday, June 15th to order. First item is the approval of our consent agenda, which includes the meeting agenda. Does anybody want to pull anything or just no? Can we have a motion to approve?
So moved, Madam Chair.
Second?
Sullivan seconds.
Thank you. And we'll do a roll call vote. Commissioner Mills,
Aye.
Commissioner Sullivan,
Aye.
Commissioner Storley.
You're awful faint. What happened?
Am I?
Yeah,
Maybe I'm too far away from my microphone.
there, that's better.
Okay. Was that an aye, Commissioner Starley?
That was an aye and then
Okay,
you're faint.
Mr. Linehan
Aye.
and Commissioner Swallison
Aye.
and Ms. Orest.
Aye.
And Commissioner Hawkins is also an aye. Thank you. We've moved on to our next item, which is a staff report and for in-home support program update. So I will turn this over. Allison, do you want to introduce?
Just excited to have Anita and Martina share about the in-home support program this morning. Thank you.
Oh, good morning. Yes, I have a PowerPoint presentation. You received it ahead of time, so you might have had a chance to look through it. I will share my screen. So I'm the designated program coordinator, and Martina, who is over all of adult services, is the designated program manager. And we would like to visit with you today about the in-home support program. The in-home support program, of course, comes under Cook County Public Health and Human Services and is part of the county's mission for supporting the health, safety, and well-being of our community with core values of accountability, respect, integrity, honesty, and partnership. For those of you who aren't real familiar with the program, or just as a little bit of a review, the first couple of slides, the in-home support program goal is to provide caring individuals to help community members maintain independence. And the program works with any resident in the county who is age 65 or older, is eligible for the program, as well as anyone 18 or older who has a disability. How are individuals supported? The bulk of what we do, a lot of what we do is cleaning and organization. So housework and organization, things like cleaning the bathroom and the kitchen and doing laundry and all those kind of tasks. In some cases, individuals have difficulty preparing meals for themselves, and so the service provider may help with meal preparation. A lot of times they'll prepare a meal and then portion it off into smaller portions and freeze so that the individual has other meals throughout the week or the month that they can utilize. Another big part is transportation. We will provide errands, either running errands for the client or they may go along on errands, and then medical rides as well. So sometimes people have a doctor's appointment in Duluth, for instance, sometimes to Harbors or even farther. There's one time last year, we took an individual to Rochester for a medical procedure. So those are our big part. And then respite care on occasion, where there's a caregiver in the home, maybe someone has dementia, for instance, and needs supervision 24 hours a day, then the service provider may go in for a portion of time to just provide companionship and support for that individual so that the caregiver can go out and do other tasks. Companionship and personal support can be separate categories by themselves. They also are incorporated into every aspect of the program. And Martina may step in once in a while to add to what I'm saying. You know, Cook County In-Home Support Program is essential. It's an essential service. Our program meets the needs of some of the most vulnerable people in Cook County. It enables elderly persons and people with disabilities to stay in their own homes versus, for instance, going to a long-term care facility. So they're able to stay in their homes for a longer time. It also provides companionship to some of the most lonely people in our county and ensures that the needs of vulnerable Cook County residents are being met. So it was definitely an essential service during COVID-19. Some of the challenges have been keeping up with constantly changing needs and expectations. I'm sure you're all aware of that. Keeping tabs on communications coming out from Department of Human Services, Public Health, departmental things within our own agency, and just keeping up with the ebb and flow of what's going on with this pandemic.
Anita, if I could just interject here, I just wanted to say that with our particular program, it's so unique. I've not yet heard of another program like this that's being run through a county organization. And when the pandemic started, we were really, really trying to find guidance from DHS, clear guidance from the Department of Human Services as to how we should operate. And what we found is that there was not clear guidance. And so we really had to rely on the information that we were receiving from different sources, like within our own public health department. We connected with local partners like care partners, asking, what are you doing right now? How are you operating? And we also connected with partners within the region. So it was a lot of work to ensure that we were proceeding in a way that was as safe as possible, while also allowing service recipients who wanted to keep receiving the service to keep receiving the service.
Yeah, so that second bullet point, ensuring that service recipients' needs are being met, and at the same time, ensuring that service providers were comfortable continuing to work with all the information that was coming out and the concerns. And then also making sure that service providers had the supplies they need. Service recipients normally provide the cleaning supplies that the service providers use when they go into their homes, but there were additional needs during this time. And so thankfully we were able to reach out and get a grant for that, because we just did not have funding to provide the extra supplies. So that's kind of comes over to the victories side. But first of all, we did continue when other businesses and programs were shutting down. Obviously, a lot of businesses locally had to shut down for portions of time last year. But also, as we reached out to regional and even statewide partners, some of them were discontinuing services to very needy people, just because of the complexity of the situation. Most service recipients' needs did continue to be met without interruption. There were a few who chose not to have, actually several that chose not to have services during the pandemic because of not wanting to risk someone coming into their home who also is going into other people's homes. And we also put any new referrals on hold for a large portion of the time because of the concerns. And when I say most service recipients' needs continued to be met without interruption until recently, I'll talk about that shortly, but we're in kind of a tight spot right now. But referring back to supplies, we did get a grant through Arrowhead Area Agency on Aging. And through that, we were able to get masks, hand sanitizer, disinfectant wipes, disinfectant or sanitizer, and gloves as well. And prior to the grant, when the masking mandates began, initially there was a small donation that got started with some masks, and then the EOC provided cloth face coverings that were made by volunteers. So that was really nice. And service provider feedback has been really good too. That safety measures that the program implemented made them feel safe while doing their work during the pandemic. We had very clear protocols and procedures and policies having to do with hand washing and masking and sanitizing and so on. One service provider, if you read the newspaper article that came out Friday, for instance, she said, "I appreciated that the county had protocols in place, yet we had the flexibility to decide if we were comfortable continuing with various aspects of the job. That personal concern, taking both the clients and our own concerns into account, was greatly appreciated." And I guess one example might be the face coverings. They had the choice of the surgical masks that we got through the grant, cloth masks that we had made available. Face shields were available for those who maybe couldn't tolerate masks. One service provider went out on his own. He said all of those made it hard to breathe. I'm not sure if he tried the face shield, but he started buying different ones from Amazon and ended up with this face covering that had a filter, like an air filter in it with a battery so that he could breathe purified air. Some providers would go, take a little more breaks to get out of the house and just pull their mask off and breathe for a little bit, those kind of things. Communication was huge. We just had to communicate. The Public Health and Human Services Administration regularly communicates information to the department. So most of that would come to me through either Martina mostly, sometimes directly through Grace Grenager. And then also the program coordinator, myself, I participated in a number of committees. Regionally, Arrowhead Area Agency on Aging began, it's all more than a committee. It's this, they call it Base Camp, and developed this website where every day I get emails. Martina and I get emails regularly where people are just communicating, this is what we're doing, these are resources, what are your, how are you handling this situation? So a really great way to collaborate with regionally. And then in the area, there was for a time, I participated in the Transportation Support and Logistics Committee as we were trying to figure out how do we safely transport people. So planning and finding consistency in that. Care Partners got a grant through Northland Foundation and started a local aging coalition. And so active in that committee, as well as the ongoing adult care team, adult protection, that meets once a month. We too would, as we collaborate for vulnerable people in the community locally, a lot of what's going on with COVID came up in those discussions. Let's see. I also collaborate with Public Health and Human Services Administration, and we developed, as I mentioned earlier, protocols and procedures, and those were, screened through Grace Grenager, and communicating regularly with service providers and service recipients. At the beginning, a lot of phone calls, calling every single service recipient to check in and see, what are you comfortable with and how are you doing? Regular email communications with service providers, sometimes almost daily at first, to just communicate as new information came out, and we were trying to be sure that everybody was on board and consistent in what we were doing. And then letters and flyers going out to both service recipients and providers too, so that they would have everything in writing as well. Current COVID-19 protocols. The service provider will call the service recipient the day of their scheduled appointment with them. First of all, the service provider needs to ask themselves, how am I feeling? Do I have any of the COVID symptoms? Take their temperature. They record their temperature so on their timesheets, so or their billing forms. So each month, I know that everybody's doing that. The service recipients are asked also to take their temperatures, and the provider goes through the typical COVID-19 screening questions with them before they go into the home. Starting about mid-year last year, we began running errands for service recipients and not asking them to stay home instead of going along on errands for their safety. With the new protocols coming out from the governor's office, we have resumed being able to provide errands with the service recipient riding along. And again, there are procedures in place. We ask that the service recipient, for instance, sit in the back passenger side of the vehicle, and there's sanitizing and with medical rides, I just want to kind of veer over to that too. Medical rides continued, but were limited last year, primarily due to a lot of medical appointments became remote. But now we're seeing a large increase, and maybe it's partly making up for that. But during all this time, in addition, the provider and recipient have been required to wear face coverings in the vehicle. Currently, we just recently updated that to say if to consider if they've been vaccinated or not. And if not, we ask that they do continue to wear face covering. If they have been vaccinated, that it's optional. So in the home during this time, just the regular COVID-19 protocols is, maintain social distancing, staying 6 feet apart as much as possible, washing hands frequently or using hand sanitizer, and recommending the use of hand sanitizer if they're unable to wash their hands frequently, wearing the face coverings, and just extra care in sanitizing surfaces. This kind of shows an outlay of where services are in our county right now. We have active 45 people who are receiving services in their home, with 11 more that are requesting services. And right now they're on the waiting list, not because we have withheld taking new people at this point, but because of lack of service providers to provide services. Service recipients that are transportation only, there are 13 more people who utilize our service just for transportation, rather than the service provider going in the home and providing homemaking and other tasks. And again, the 11 is the full amount, 58 people total, with 11 on the waiting list. There are currently 14 service providers, although one has put in a resignation, and she has cut down on services and is only providing medical rides right now. She's moving out of state in the middle of July. But there's the breakdown of where people live at this time, as far as East End and West End and Grand Marais area, the service recipients and providers. And So in the past year, 7 service providers have resigned, and the reasons vary, but 2 of them, it wasn't, they did not themselves have COVID-19, but it was related to the pandemic as to their reason for resigning. Actually, I've hired 7 people. However, the people that have been hired either have very reduced availability, such as I can only work with a couple people, or there are a couple that are seasonal. Actually, one is, it sounded like it was going to be perfect at first. One is October to April, and one is November to April, and one had said originally May to October, but she's taking the whole month of August off, so that throws a little glitch in there. So as far as service recipient needs, there are 2 current service recipients who do not have a service provider at all right now. They're just waiting. 3 current service recipients who are working with, this summer person. So August is going to be a rough month if we can't get someone hired. And then 2 are receiving partial services where there aren't enough people available to meet their full hourly requirement, but they're at least getting some of their needs met. And again, 11 on the waiting list. The way that payment options work for the people in the program, some have waivers. There are various waivers, and the alternative care and elderly waiver, the AC and EW waivers, they increased about, it was a year and a half or 2.5 years ago, I can't remember, but to $19.36 an hour, whereas everybody else is at $18.44 an hour. And that's for all ages, whether they're, 18 and above with a disability and someone over 65. The sliding.
Anita, just to jump in, just to explain the waiver, it's for individuals who are MA eligible. For people that are under 65, they would also have to be certified as disabled to be on a waiver. And it's just additional monies from the state to pay for home and community-based services.
And so the county assists with a sliding fee scale for anyone 65 or older who qualifies for the program. And that rate has been based on the $18.44 an hour, the lower rate. Private pay most are around $25 an hour. There are a couple that are paying $20 an hour and have been for like a couple of years. And private pay people, as long as they qualify for the program, they can be anyone with a disability or age 65 or older. Adult mental health, sometimes there are some clients who receive funds through that program, and that also is based on the $18.44 an hour. Right now we have 11 waiver clients that are EW or AC, and one that is one of the other waivers. And then the sliding fee scale, we have 18 service recipients, private pay 10, and adult mental health 5. So that means there's 24 people who are at the $18.44 an hour, 11 at $19.36, and 10 at the $20 to $25. And that's what the service provider receives for providing their services. The waiver rates are determined by Minnesota legislature. So a concern right now, especially, has been retaining service providers. Again, this base rate of pay has remained the same since 2015, the $18.44. The state has not changed that rate. The only change was when the EWAC went up to $19.36. And if you look at from 2015 until now, that amounts to about 1% per year for those people. And then the private pay is $20 to $25 an hour. I was just curious because it has been hard to retain service providers, and we get really, really quality people. I do want to talk about that because right now we have 6 people with bachelor's degrees, a retired RN, a certified physical therapist assistant, a former assistant general manager for a large hotel complex. So she had a lot of different tasks, including supervising the housekeepers. We have a small business owner, and people with professional cooking and maintenance and housekeeping experience. So the job itself really attracts people with strong qualifications. It's just, wanting to retain them. And so I was just comparing. So the job is a little bit different in some ways, but compared to a local independent homemaker, you can see just these were some ads over the past few months on Boreal that I saw. In addition, right now, there's one that says Loon Lodge on Superior is offering $30 to $40 an hour plus an $8 trip reimbursement. So if the homemaking, housekeeping part is their main interest or skill, they're going to do better elsewhere. But again, the job entails so much more than that. Wanted to look at some other statistics, just showing here the number of hours over the past few years that, and this is not including private pay service recipients. We do not keep track of their hours. That's between them and the provider. I mean, I know that so-and-so goes into this person's home 6 hours a week or something like that, but I don't keep track of their overall hours. So in 2018 and 19, around 3,000 hours per year that service recipients are being paid at the 1844 or 19 service providers, sorry, at the 1844 or 1936 an hour. We were curious, it went down slightly between those 2 years, and just no time to sit down and try and figure out the data as to why that was. But on kind of a scenario basis, and one thing I thought about was one service provider, for instance, had a client who was on the elderly waiver who went off the waiver, and he took on 2 new private pay service recipients. So again, not knowing the full balance between private pay and others, that might be the explanation there. But obviously last year, there were reduced hours because of some people declining services, as well as putting new referrals on hold. And so again, there's the rates of comparison. I mainly talked before about homemaking because, as you can see, that's where most of the hours go. If sometimes there's been chore services, for instance, there was an individual in Grand Portage who did not have drinkable water. And so each week the service provider would go to the spring at Grand Portage and bring water, haul water back to her home for her. So that was more of a chore. And the definition is based on the Department of Human Services definition as to whether it falls under homemaking or chore services. But you can see, like, if it's chore services, or if the sole responsibility is adult companion, boy, the wage goes way down. And then respite care is a little better. Again, just looking at what an independent homemaker would make as well. So I was just curious, if service provider were county employees, where would they stand? And in consultation with Lori Erickson, and Lori, you can pipe in if you need to add anything, but I just was curious if they were making $15 an hour, which in some areas is minimum wage, or $20 an hour, how would that play out? And you can kind of see the breakdown there, primarily looking towards the bottom of the 2 boxes, the total per hour, depending on if they have single insurance or family insurance. For the $15 an hour, it actually comes out to between $22.25 and $27.60 per hour. But that's counting the value of the benefits, such as health insurance and retirement, FICA, Medicare, long-term disability, life, AD&D, deferred comp, workers' comp, FIBA. We also, county employers, receive paid time off, which service providers do not. And then if it was $20 an hour, again, it would be even more. So retaining service providers. If they were a county employee at $15 an hour, as we just mentioned, that would equate to $22.25 to $27.60 an hour, Plus there'd be additional costs for the administrative time. I'm sure even my job would change, as right now they, as independent contractors, I set them up and get them started with clients, but they, if one of them is sick or goes on vacation, as much as possible, they work it out with each other. If there's a need, then they contact me and I find a substitute, but there would be a lot more time involved that way, as well as accounting and etc.
And the reason, just to interject, the reason we were looking at this is because we were trying to figure out, would it make sense for us to try to actually create a position where we hire a service provider or a couple of service providers to actually be county employees? Would that incentivize people to become service providers? So that's why Anita was looking into the cost of that. And she'll talk more about what we ultimately landed on.
So, I mean, I've already talked about what they're currently paid, private pay, and so on, but 100% of the state reimbursement rates are currently passed directly over to the service providers. So we don't take anything off the top on that. And so our suggestion, or my suggestion, is to ask you if you would consider supplementing an additional $2 an hour for service providers. One thing about being independent contractors is that level of skill, I think, that comes in. We would still be below what it would cost if they made $15 an hour as a county employee. With no wage increase since 2015 for most of the reimbursement rates, the 1844, adding $2 an hour would come to a 10.85% between 2015 and 2022, or about 1.55% per year increase. Although I think in 2015 it was mid-year when that pay increase came. I wasn't here at the time, but so if, looking back where we looked at 2018 and 19, let's just say average number of hours per year that this would entail would be about 3,100 hours. The total extra cost to the Public Health and Human Services budget would be $6,200 a year. So that would increase, the 1844 to 2044 an hour, and those with EWAC to 2136 per hour.
And again, we're passing everything that we receive from the state in reimbursement for providing the waiver service through to the service provider. We're not taking anything off the top of that to pay for our admin costs. And Anita spends a great deal of time reviewing the time billing every month, signing off on it, and then on our fiscal side, they have to also review that and write out the checks. And if we add this $2 an hour increase in, it's going to create a little bit more work. We're going to have to develop new forms to account for that. But again, we really see the importance in reimbursing the service providers more than what they're currently receiving. And this would come from our PHHS budget.
And I wanted to mention too, Pamela Dixon had suggested that I calculate the number of hours I've spent on recruitment activities, and it's hard to sit down and plan it all out, but I did that for most of March. In March, I actually had 3 resignations, one who really gave a 1 week notice, 2 weeks notice, but she had already planned vacation the second week. And then 2 that stayed on longer, including the one that's actually leaving mid-July. She was willing to extend and keep helping longer. But in March alone, I spent somewhere around 30 hours between juggling the person who resigned. She had, I believe, I can't remember now, but about 10 service recipients. So trying to get their needs met, advertising for new people, getting one new applicant and getting that person trained in, and that overflowed, I think, into April too. So a lot of my time gets spent when we have turnover like this. That's time that I'd like to spend, or, you know, there are other needs. In fact, like trying to keep up with DHS requirements and all of that. So that's just another factor in there. But overall, some challenges and gratifications, they're pretty similar year to year, except right now, like I say, the challenge of retaining service providers seems more so than before. And then that balance, always making sure that the service providers are getting the hours and they want, and the recipients' needs are being met, and that people are a good match for each other. Also, service provider training. DHS, every so often, sometimes mid-year, they'll throw in a new requirement. And so trying to make sure that we're meeting the DHS requirements for training, and when possible to, you know, a lot of times the county has wonderful extra trainings that are appropriate, but a lot of times the service providers are very busy and they don't participate a lot in those, but once in a while they do. But anyway, some gratifications, just really fabulous feedback. Oh, that's the rewarding part of my job, as well as the service providers, is the feedback from them. And then the providers too get a lot out of doing this kind of work. And just knowing that we're providing an essential service to the most vulnerable people in the county. Again, I just wanted to share from the article a couple of quotes. A service recipient said regarding service providers, "They are my lifeblood. The difference between freedom and captivity. I don't think I could still be at home without the kind and generous support of my in-home support provider." And another service recipient, "The people who do this work are amazing, and I will be forever thankful for all they do for me." It's an important, essential service. And then one more quote from a service provider: "Some of the people are alone all day, and the only person who comes in and sees them is you. You're their only access to the outside." So service providers, I think the biggest thing that does retain them is that internal reward. There is a real gratification that you can't get by just being a housekeeper who goes into someone's home or works at a hotel. But that in itself doesn't always keep people from leaving. So those are my thoughts at this time.
Can I just add something too, Anita? So I just want to let you all know what a phenomenal job Anita has done in her time as the in-home support coordinator, especially during the pandemic. She was constantly having to change procedures. I would learn of something and I would reach out and say, "Anita, I think we need to change this." And she would do it. She would rewrite the procedure. We'd have conversation. You know, we talked through everything, every piece of this along the way to make sure we were addressing things appropriately. But she would have to create the procedures, change the procedures, communicate that all, and then sometimes in a matter of weeks, do it all over again. She has been such a strong advocate for the program and for the service providers. This spring, she reached out to me and said that she wanted to do something to thank the service providers for continuing to do the work during the pandemic. And so I offered that I had received a little thank you gift from the North Shore Healthcare Foundation for being a part of their volunteer piece with the vaccination events. And that really meant a lot to me. I got a handwritten thank you note. And so Anita took that and she made a really, really great thing happen, in that she got some really great gifts. We were able to use some donated monies to purchase gift cards and also give the providers handwritten cards as well to thank them. Because we don't have money in the budget for this type of thing, it was really great to be able to still do it just do it creatively. And it seemed like it was really, really well received by the service providers. So Anita just is phenomenal at her job, and I appreciate all that she has done.
Thank you, Martina. I mean, we have a wonderful team here, support from the top down. It's really nice. And regarding that, there were some community businesses that helped, put in donations towards those gifts. And the cards we passed around the department. And so the social workers and the managers signed the cards too, and said how much they appreciate what the providers do. And so it was really meaningful to them. But thank you so much for your time. Any extra questions before we leave? Ginny?
Yes, thank you. Great report, Anita. I really appreciate there again, all your efforts and everyone else's too. Care Partners does a lot in our community. Is there any way that you can work with them?
Oh, we do collaborate a lot with Care Partners. We refer people back and forth. Yeah, and then we're on the Aging Coalition Committee along with other community members too, to best support elderly people in our community.
Great.
The difference with our program is that we're able to utilize waiver funding to pay for the services. So for our individuals who are on the state funded waivers, we can use that to pay for their services versus them paying. So we're able to meet the needs in a different way than Care Partners, and vice versa. They're able to do things that we're not. So it is a collaboration, like Anita said.
Mm-hmm.
And I can't see everybody, so if someone else has a question, just speak up.
Madam Chair?
Yeah, just a second. Can we take down the
Sorry.
the screen, and then we can see each other? And
Okay,
thank you. Yes. No, thank you for this report. I took lots of notes here, lots of questions, but yes. Commissioner Mills, did you have a question?
Yeah, well, I don't think it's a question as much as just wanting to express my appreciation for the work done and how important it really is in our community. As you so clearly stated, it is an essential service that helps the most vulnerable in our community, and that is just so important. And we all know everyone is facing challenges with employee retention, and I think it's an excellent suggestion to do that $2 an hour increase. Looking at your numbers as well, that $6,000 annually, I think $6,000 is a lot of money, but in the overall budget, I think it would be money well spent and have a good impact for the retention of these contracted workers. And I really appreciate you looking into the reasons of why this challenge is happening and potential solutions. So thank you for presenting that as well.
Thank you.
Yeah, thank you. I know some recipients who are very grateful for the services that are provided by this in-home support. So thank you for all you do. I have a question about the DHS requirements for training that you mentioned. How many hours is that required, and do they reimburse for that?
They do not actually. A few years ago, I applied for a grant because at that time, service providers were not being paid for their training time. And that was a major concern for some of them because they have very busy lives, and to take that time out and not even be paid for it. And we received a grant for that year to pay for training, and then made the request to the county to cover that. So their hours are covered at $18.44 an hour. And I have not requested that be increased, but when they start for orientation, it's about 12 hours. And, you know, that used to be a mandated number of hours. Now it's mandated topics. And they don't put necessarily a number of hours, except there is an 8-hour initial training, and then 4 hours on one topic every year to repeat that. But it probably averages, gosh, 8 or 10 hours a year. I can't remember what I wrote in the original budget request, because I did give some of that request information to Martina.
That's okay. You don't have to provide it right now to me. Was just curious about how this all works. So thank you. There was one other group you mentioned at the beginning, and I didn't write it down, or I didn't get it written down. Arrowhead Regional, one of the, committees that you work with. Could you?
Arrowhead Area Agency on Aging.
On Aging. Okay, thank you.
AAAA is what they go by too.
I saw that in your report, and I'm like, I'm trying to learn all these acronyms. So thank you for clarifying that for me. Anybody else have any comments or questions? Administrator Yorkie.
Thank you, Madam Chair. I just wanted to echo Commissioner Mills' thanks to Anita for a great presentation, and to Anita and Martina and all the folks who help provide these services to residents in our community. It is such important work, and it's clear that for many people, this is really a lifeline. And I'm grateful that you're doing this work. I'm so grateful. And I also wanted to observe that what I heard in your presentation is something that I think is a real strength of PHHS as a department, which is that you're always looking to make changes to improve your ability to serve the community. The department's really responsive, and when circumstances change, the department looks for ways. I'm sorry. My allergies have been bad lately. The department's always looking for ways to enhance services, and through the pandemic to make the changes needed to make sure that folks continue to receive the services that they need. And I just think that's a real strength of the department, and want to thank you all for taking that approach to serving our community. Thank you.
Thank you. And if that's all, I guess Martina and I can head out.
Thank you. I appreciate you taking the time to do such an awesome presentation.
Oh, thanks. Thank you so much for inviting us. We really appreciate it.
Thank you. Bye.
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 I wasn't able to hear you very well, Commissioner Hawkins, as your head was turned, but it sounded like a handoff for my report.
Yes, it was. Thank you.
And I have another PowerPoint to share to help guide my report this morning. So if anyone needs just a break from the screen, if you want to take a look out your window, or maybe move your body or stand up for a minute before I go into my update, I invite you to do that now while I start my screen share. All right, are you able to see the full screen of my presentation and not my notes? Great.
Yes.
All right. Never quite know. Okay.
You're on mute now, though, Allison.
Thank you, Commissioner Mills. I'm going to start with some staffing updates this morning. So this week, last week and this week, we are conducting interviews for social work vacancies in our department. The first being the substance use disorder and co-occurring disorders case manager position. This is a vacancy that was created when one of our staff resigned earlier this year. We are also interviewing for the Children's Mental Health Therapeutic Support Services position. And again, both of these positions are replacements. The position descriptions were modified slightly to include both case management and then some therapeutic support skills components as well. And these were revisions that we made in light of changes in available services locally through Ascend services. We are also looking at the expiration of temporary public health staff contracts at the end of June. Thank you for approving the extension of one of those contracts through July. Grace and I will be sharing more information about the request to maintain public health capacity later on in my presentation. There we go. So agency-wide, some highlights of what's going on in our department since we last spoke as a board. Our adult and home and community-based services team recently completed an audit with managed care provider Blue Cross Blue Shield. The audit results were very complimentary of the care coordination services provided by our staff. So I just want to thank and recognize the team members that were involved in that audit and involved in providing very high quality care and services. Also, the transportation survey that our department is conducting with the help of Sarah McLeod, who's a Master of Social Work intern, and in partnership with the North Shore Healthcare Foundation, was extended through last Saturday. In addition, we also made options available for submitting a paper survey throughout the county. And again, our plan is to bring a summary report of those results before the PHHS board later this year. Within Children and Family Services, the team is short-staffed right now. We have a couple of staff out on leave, and as I shared, interviewing for a few vacancies. So a lot of transition right now for that team, also experiencing an uptick in requests for services. It's pretty busy in our offices right now with the courthouse resuming serving people in person with the restriction lifted in June. Also within the Children and Family Services team, continuing to move forward with additional development of services and focusing on our community partnership initiatives with the reconvening of the multidisciplinary behavioral health team later this week. We'll be meeting with some of our primary medical, law enforcement, and human services partner agencies to review what has changed in the last year with COVID. We haven't been meeting regularly during the pandemic. It's been about 9 months since that team has come together. So just reviewing roles, processes, communication needs as we prepare for another busy summer season in Cook County. We are also working on 2 program and policy development initiatives to further strengthen our local behavioral health response resources. One, as I've shared with you all, the pursuit of that daytime crisis response certification to formalize that role that has fallen to our agency to provide that daytime crisis response. And the second being the development of a policy to formalize our role in after hours call out. And this is an internal resource where our human services staff provide consultation after hours to law enforcement. Within our economic assistance and healthcare team, we are promoting MN Benefits as a new online application tool for county residents to apply for nutrition assistance and cash assistance programs. that is now available online. And as I said, it's a streamlined application process. It's a lot quicker time commitment to file that application online. Our staff are busy with the renewals for SNAP and cash programs resuming in June as well. Within public health, staff are involved in the teen vaccine events and of course, coordination of outreach to continue to promote access to and information about the vaccine. Another effort underway within the department is looking at our workspace within PHHS and modifying some of our offices to be able to accommodate more staff returning to the office. Our staff shifted around quite a bit over the last year to minimize shared spaces to the extent possible. So we're proposing to add more shared workspaces and free up additional private meeting areas for staff to be able to meet with the people we serve and not have to disrupt shared spaces within the department. Also in the agenda materials, I shared a flyer and application materials for an ACEs presenter cohort training that is being sponsored through our North Shore Collaborative. The link is in the agenda and we're working to promote that for as many people as possible who are interested in going through that training. On the state level, the special session began on Monday with a focus on setting the state budget. Unless the legislator can come to an agreement on the state budget by the end of June, this could result in a partial state government shutdown. Sounds like that's unlikely at this point, but we are starting to receive information from the state, both MDH and Department of Human Services, about what this would mean for some of our grants and the staff that provide technical assistance to local agencies. And we are already seeing the impact with delays on grant award notifications that our staff have applied for. A joint letter was sent from AMC, MAPSA, and MICA, which is the Minnesota Inter-County Association. One of the House and Senate leadership. One of the joint priorities set forth is the codification of some of the waivers that were put into place during the pandemic to allow flexibility for local agencies in delivering services. And if you haven't already seen that, I can send a follow-up email with that letter to the PHHS board. So next, I'm going to go on to share some of the context and background for our request to maintain public health staffing within the department as our temporary contracts are set to expire. Any questions on the staff and agency updates before I move on to that portion of my report? Okay. So while the COVID-19 pandemic has dramatically elevated the visibility of our department within the community, even in non-pandemic times, public health has a wide range of responsibilities to the community defined in statute by the state of Minnesota. These areas of responsibility, often called the 6 essential areas of public health responsibility, as well as our 5-year community health improvement plan, define our work in public health. Last month, Commissioner and Board Chair Hawkins asked about public health infrastructure and wanted to provide a little more detail about what that means as well. As the first essential area of public health responsibility, this is the ability to carry out our basic public health functions. So sufficient capable staff, access to technology, relationships with community, as well as other levels of the public health system. So these are essentially the linkages and resources that support community health. This is from a recent report from the National Association of County and City Health Officials. Again, I'll send a link to my presentation and all of the reports and information that I'm referencing here, so you have that material and don't have to worry about taking detailed notes. This shows nationwide that there have been repeated budget cuts to local public health, and this has really challenged and stretched health departments and our ability to respond to the public. The system was stressed to unprecedented levels during the pandemic. Here is a local context, or not local, statewide rather, of what that reduction in local public health spending has looked like over the last 12 years. So Minnesota's local public health system has lost 11% of its workforce in this time period, with the number of FTEs remaining low by historic standards. This is from, again, a recent report from Minnesota Department of Health, and we'll share this with you as well. It's really neat to read, as it includes some interviews with local partners about our public health department's leadership over the COVID-19 pandemic. So for some local context of public health staffing changes within that same time period, from approximately 2008 to 2016, there were 2 public health nursing staff in our department: Joni Christensen, Amy Lacina, and Allison Heron were the staff working within PHHS during that time frame. Those staff provided an array of services, including community health leadership, nurse family home visiting, care coordination, and long-term care consultation for seniors and people requesting waivered services. These staff were registered nurses, providing a more direct care model of public health nursing, as well as the community health leadership and coordination as well. These staff worked an average of 30 to 40 hours a week, so essentially full-time equivalents. From 2016 to 2017, we had 1 public health nurse, Joni Christensen, and her role as public health coordinator, providing community health leadership and nurse family home visiting services. During this time period, the care coordination for seniors and persons requesting waivered services were transferred to social work staff within our adult and home and community-based unit. In this time frame, we did attempt to recruit for the second nursing position, but this was paused when no qualified candidates applied and during department leadership transitions in 2017. At the point that I was hired as PHHS director in 2017, this was very clearly defined for me as a primary goal in my first 6 months in how to fill that vacancy in the public health department. At that time, I went through a strategic planning process with Joni, the long-serving public health nurse, met with leadership at the Sawtooth Mountain Clinic to talk about the transition of the family home visiting project as a complement to some of the other maternal child health services that were being provided through a subcontract. 2017 also marks the beginning of our current community health assessment and health improvement planning cycle. In 2018, the Universal Family Home Visiting Program was transferred to the Sawtooth Mountain Clinic. We hired Grace as a public health coordinator after the retirement of long-serving public health nurse Joni Christensen. Bringing someone on with a strong background in that health education and leadership allowed us to move towards a more population-based public health service delivery model in PHHS. The state and CDC defines this as public health 3.0, which is the role of local public health departments acting as chief health strategist or convener in bringing partners together across silos or across systems to look at community health on a population level. In 2019, we received approval from the Public Health and Human Services Board to bring on an additional public health educator to restore our department to previous staffing levels. And in 2020, hired Kristen Dearuda-Wharton in that role. She was hired in June. Around that same time, we also brought on 4 temporary staff to assist with pandemic response using federal CARES Act funds. Andrea, Jody, Maggie, and Sadie all came on board during the summer of 2020. After Kristen resigned her position, Jody Turbo Roberts, who was working with the department as one of the temporary staff, was hired in November to fill that vacancy. And looking back even further than this, to the 1990s, when our county health department and human services department became a joint integrated service, we had many more nursing staff within health services, and those were transferred to contracted medical partners, for example, home care nursing through the hospital. This again is from that NACHO report on the importance of robust, stable funding that can be applied flexibly, and how this can really maximize the impact that public health can have on community health goals, both during and beyond the pandemic. So again, our request to add an additional permanent public health educator in our department is a direct response to both our need to meet our statutory public health obligations to the community during and after the pandemic, and ensuring that we have adequate trained staff to quickly scale up or down our emergency preparedness and response efforts to keep our community safe. This is a list of some of the CDC core competencies for emergency preparedness that we are required to ensure. And this slide, I'm going to ask Grace to give a little more background on and describe what having 3 public health staff cross-trained across those core emergency preparedness competencies, how that would benefit our response and preparedness.
Sure. Thank you, Allison. So the vision for having 3 public health staff that would be cross-trained in emergency preparedness and response would be to allow us the ability to quickly scale response activities as needed by changes in the pandemic, but also by any number of other health hazards that could impact our community in the future. Things like extreme weather events have been long the focus of public health emergency preparedness and response in the county, although they haven't been quite as much in the spotlight this past year. So when we think of emergency preparedness, I think of it in terms of a cycle or a life cycle. So there's a portion of that where we're in response mode, as we have been during the pandemic. After that response mode winds down, we move into what's called the recovery phase, where we look and see what the impact of the disaster has been on the community, try to assess any related effects that the disaster may have had. In this case, that assessment might specifically look at things that have been noted as struggles for other communities because of the pandemic, and seeing what that might mean locally. So things like mental health, substance use disorder, access to healthy food, just to name a few, to see what any sort of secondary impacts of a disaster might be. And then moving into a phase where you're looking at resilience and building up the community's capacity to return to normal or return to a place that's perhaps stronger than before the disaster. And then moving into that preparedness phase. So revisiting plans and those core capabilities set out by the CDC and MDH, so that if a disaster, a similar disaster, were to happen in the future, that we would be able to jump back into that response mode more quickly if the need were to arise. So even when we're not in full response mode, we are working on the different pieces of that disaster life cycle, not just for the pandemic, but for any of the hazards spelled out in the all hazard plan that emergency management has created for our jurisdiction. So really the vision is to have capable trained staff in 3 positions that are able to scale up or down response according to needs, and to work in the different phases of the disaster life cycle, depending on the situation in front of us. So in terms of COVID-19, we are planning for what a phased demobilization might look like. What are the data points that might allow us to scale back from response mode and move more fully into that recovery mode? Part of this will be working with partners to conduct after action reports, looking very closely at the portions of our response that worked well as those portions of our response efforts that could use improvement if we were to experience a similar event in the future. We will continue to maintain situational awareness, so making sure to connect with our partners at the state and federal level as things like new variants come onto the scene, making sure that we are keeping on top of changes in case counts, both locally, regionally, and at a state level, so that we know when it is appropriate to either scale back or move into response mode more fully once again. And again, using the lessons learned so that we're better prepared to move into any future event that might affect our community. Some of the aspirations that maintaining that third position would allow us to move toward is making sure that we're staying connected with our Minnesota Responds volunteers. That group of 70 committed volunteers has just been invaluable to the response. And so making sure that we are showing our gratitude and providing opportunities for continuing education and training if those volunteers are interested in learning more about the public health emergency response role. That's something that is a priority for us. Continuing to support our local emergency managements with their annual emergency response conference and ensuring that public health preparedness is part of that annual conference. And again, making sure that we are all up to date with skills and trainings so that we're all able to maintain those CDC core public health emergency preparedness requirements. Back to you, Allison.
Thank you so much, Grace. So as I shared, aside from focusing on public health emergency preparedness, the role of our health department is convening our community partners and our role as community health leaders, working towards the goals defined in our health assessment and improvement plan. I think many of you know this already, but I'll just reiterate that our community health assessment defines and describes those factors that affect the health of a community, what available resources exist in a community to address those factors. Within Cook County, our public health staff convene partners to look at health indicators, local data, really analyze and use that data to prioritize health issues that affect the community. In our current cycle, we began meeting in 2017 in the fall, had a series of 8 community meetings, and again, talked through what are the priority areas in need of attention, who are the people that are most affected by each priority health area, and how can we work together to address and define those goals. So these are those priority health areas that were defined by our stakeholder group. Some of the current and future initiatives for community health leadership defined by our health assessment and improvement plan. Many of these have been amplified during the pandemic. For example, behavioral health, one of our initiatives is to increase engagement with area schools and youth serving agencies that promote protective factors. We partnered with the Grand Portage Band, the clinic, and other service agencies on a HRSA-funded grant that will work on youth substance use disorder prevention. And a part of that grant proposal includes funding to support public health. Within early childhood, our staff are connected in with the Early Childhood Coalition and HUB grant for expanding access to services for families from birth to age 5. Housing is another priority area defined by our health assessment and improvement plan. And I think a great opportunity for public health to really partner with local entities that are working to address the lack of safe, affordable housing in our community and really provide that lens of health equity to ensure that those who are most disproportionately impacted by lack of access to affordable housing have a voice. Additional priorities defined in our health assessment plan include access to specialty healthcare services. This work is primarily being led by healthcare partners. However, the transportation needs survey that we're involved in is certainly connected to this as well. Another area where our human services staff are plugged in and providing support to address goals is with supporting members to age well in Cook County. Martina and Anita both shared that they are a part of that coalition work being led by care partners. Anything else, Grace, that you would add here related to community health leadership?
I think you covered it.
So some additional goals, aspirations for community health leadership. Grace, do you want to take this one as well?
Sure. So as I talked about that life cycle of a disaster, as we're moving toward the recovery phase, one of our goals is to revisit our community health assessment, community health improvement plan to see how the COVID-19 pandemic has affected the different priorities that were set by that community group in the 2017-2022 cycle. Because we know that it has had more effects than just individuals in the community becoming ill with COVID or needing to quarantine and isolate. It's been a very challenging year in a number of respects for our community. So one of the first steps forward will be to really gauge and assess what we're looking at in terms of community health as we move forward. This is the second bullet is more an annual process. The public health funds that the PHHS department facilitates the grant making for with a group, a subcommittee of the Public Health Human Services Advisory Committee. That's an annual process where nonprofits are invited to apply for funding, and then we facilitate the grant review and grant making process. So that's something that will come up later this summer. As we mentioned before, one of the skill sets of public health is to really seek additional grant funding. So having that third position will provide us with the capacity to actually seek out and apply for grants to further the work of our community health improvement plan. It is challenging to find that time with the current, without having that third person to add capacity to public health. And to provide technical assistance to staff and subcontracted programs that we have through the clinic. I mean, I think the technical assistance through the pandemic has really come to a new level, and I think it will continue as we move on into that recovery phase. We continue to get requests from schools, businesses, agencies throughout the community as to how to scale back some of the operational changes that were put into place because of the pandemic. And on a more ongoing basis, the subcontracted programs we have with the clinic, we work very, very closely with those staff and those contracts to ensure that they have the support that they need to provide a high quality of service delivery to the community. We've talked both with the clinic and internally about the community health worker model, which is a peer support model to provide services to the community, which is a reimbursable service through medical assistance. So we've done some pre-planning to see what that type of service delivery model could look like for the community, and really diving into that and seeing whether there's a place for that as we move into the recovery phase would be a goal for public health. Addressing the decline in childhood vaccination rates. This is really important. We know on a national and state level that childhood vaccination rates have plummeted throughout the pandemic, and we want to make sure that we're working together with our partners at the Sawtooth Mountain Clinic and Grand Portage Health Services as well to try to address that decline on a local level and make sure that parents know what recommended immunization schedules look like for their children, that they have the support to get those children into the clinic for those vaccinations, and that they have an opportunity to ask questions and receive evidence-based information on the importance of those vaccinations. And then the final is just this past year, we really have done quite a bit of public information and outreach related to the pandemic, but I don't think that stops with the pandemic. I mean, even in non-pandemic times, it's really important to us within the department to be communicating with the public on what it is that we're working on, why, how it is that people can engage and get involved and provide feedback. And so that'll be an ongoing priority and core function for public health moving past the response phase of the pandemic.
Thank you, Grace. So this is provided just as an illustration for a 3-month average of staffing within public health. As you can see, we're at essentially 3 FTE right now, including our full-time public health supervisor and public health educator, and the 3 temporary public health staff. This does include overtime and comp incurred by our supervisor and health educator. This is just another way of looking at the same information. So barring any further action by the PHHS board, we would see a reduction in approximately 40 hours per week staff time in public health effective August 1, as this does assume the approval of the temporary contract extension. Just to reinforce, the ask before you today is that a strong baseline capacity for our preparedness. Our challenges in being able to scale up in short notice are a factor as well. I think we were really fortunate last year to have a number of highly qualified, capable, interested people who are willing to support our response efforts on a part-time basis during the pandemic. So the extension of the contract for our temporary public health educator through July is the fiscal impact will not exceed the original amount from the contract entered into in January. So there's no unintended budgetary impacts there. I do not have the item for board action related to the SHIP, making the SHIP position whole and adding additional hours to support that position. But similar to our request to post for a public health educator, we would be able to pursue state and federal grant funds to offset the cost to the department. Still waiting to hear more from the state on budget, but that could bring additional grant funds to support our response efforts. Another opportunity being the American Rescue Plan funding coming through the county. As I understand, a subcommittee will be convened to review requests and make recommendations. So we would advocate within PHHS for including some of these additional public health staff hours as a potential use of those funding. We would also support use of fund balance for the unbudgeted expense for 2021. We did see a significant return to fund balance in 2020, and a major piece of that was unanticipated revenue coming into public health to support our staffing and response efforts. So I think the justification of using some of that fund balance that was returned in 2020 to support maintaining capacity in 2021 is well justified. It's not a sustainable long-term funding solution by any means, but in the short term as a stopgap while we pursue additional state and federal revenue sources to support these positions and include these additional hours in our 2022 department budget. Just to provide an example of how we review grant funding within the PHHS department, as our public health programming staff and fiscal staff meet each month to review all of the public health grants that both support our staff time and our subcontracted programs. So we would be including these positions in that process to ensure that we're pursuing all available revenue to support these positions and offsetting the burden on the county levy.
Excuse me, Allison. We've reached 10 o'clock. Again, it happens so quickly here in this meeting. And I just want to ask advice of you and Mr. Yorkie about what we should do about the committee of the whole meeting.
Thank you, Madam Chair. And thank you for noticing the time. So this situation is occurring fairly regularly, and I feel like we probably need to be blocking more time for this meeting because there's a lot of important information here, and I don't want it to get short shrift. So moving forward, I think the alternatives would be either starting this meeting at 8 o'clock or pushing the start of the committee of the whole meeting back to 10:30. So that's, I think, something we should look at moving forward. But in terms of today, there are a couple of important action items, and I would like the PHHS board to be able to address those before we adjourn. So I would offer that we could start the committee of the whole meeting perhaps after those actions are taken, and then perhaps skip the committee updates this time around and get back to that next month.
Sounds good. Thank you. Yeah, I think that the action items are going to take a little bit of time of discussion here. So I just want to make sure we don't rush things just because we're watching the clock. So, yeah. Okay. Thank you. Sorry for the interruption, Allison. Go ahead.
I was finished, so happy to take any questions from the board regarding the report and our items for board action before you this morning.
Anybody have any questions or comments? Commissioner Mills.
Thank you, Madam Chair. And I don't think I have a question right now. It's just, you know, there's so many moving parts, both with the pandemic and our funding and positions, either individuals leaving or just reevaluating what our needs are. And so I really appreciate, and I've said this before, I probably say it every time, but I really appreciate the flexibility within the department to reevaluate the needs and to find creative ways to meet those needs. And you know, it's an ongoing process, and you know, just the discussion we had at the CHB meeting as well, talking about public health support and funding over the years. I think you used the same graph, and that was going to be one of my reports is just talking about that. But it's something that I think needs to be addressed also at the state level. But we need to show support, I think, at the community level here, because we certainly have demonstrated the need, and just I think we're on similar pages as far as wanting to do more preventative things to help our community rather than needing to respond. And so going forward, I see it making a lot of sense to have those public health positions, especially public health educators, and really hope that by supporting these positions, that we are in fact doing things that will put us in a better position in the future for our community.
Go ahead.
Thank you, Madam Chair. I think our public health people have shown their value over the past year and a half. I think that our outcome with the pandemic is very good proof of that. I think it's important for us, given the aging of our population, as well as young families and young people. I think the better we can support our public health people in providing the services and the education that's necessary, the better. So I'm fully behind supporting Allison's request.
Other comments? Thank you. Commissioner Mills?
Thank you, Madam Chair. And yeah, that just triggered another thought in my mind too, is I appreciate the breakdown of the hours that are being put forward, and just it can really help us with budgeting to have the more permanent position, to know what's going to be happening. And right now we do have funding and resources to back us up with both the American Rescue Plan and other opportunities for COVID relief. But that, in my mind, just laying that out as you did, Allison, it really helped. It really helped me understand that better. So thank you, particularly with that too.
Commissioner Starley, go
Mhm.
ahead.
Thank you. Well, I use the word potential because I really need to know that the 83,438 will be covered by either the health department, public health, or American Rescue Plan, or how's that going to work? It just says potential.
I was intentionally tentative in my language around access to the rescue plan funding, just knowing that I don't want to get ahead of any broader community engagement efforts that are underway to get advice on how to best use those dollars. So we will be seeking that out as an opportunity to offset some of the cost to support those positions. But again, as a stopgap measure, we have the ability to access our fund balance this year and then pursue additional grant and revenue sources, either through the state or federally, to support these positions and offset the burden on our county levy.
I also had that concern, the timing of this. I really do appreciate the work that the Public Health Department has done this last year. We all know it's amazing. They went above and beyond. We are so very grateful. But the timing of this request concerns me, that we are adding a permanent full-time position to go on, and we have not convened our recovery committee yet. We have not convened our budget committee yet. And we as this board are putting this at the top of the group and telling those committees, well, automatically we want this at the top. I'm not saying that it shouldn't be, but I just feel like we're kind of circumventing the process of the whole budget deliberations. And I just question the need to do this today. So that's my comment for that. Administrator Yorkie.
Thank you, Madam. Oops, I am unmuted. Great. Thanks, Madam Chair. Just a couple of notes. We do have meetings planned for next week, 2 meetings to engage our community partners in discussions about how to best use the American Rescue Plan dollars. So that discussion will be held soon. I feel that there's a strong likelihood there's going to be support for using some of those dollars for the purpose that Allison is requesting today. And I agree with you. I don't want to get ahead and make assumptions about how that conversation is going to turn out. But clearly this need aligns very much with what the rescue plan dollars are intended to be used for. The other thing that I would note is that public health is not just about emergency response. And we've certainly seen that the value of the work that Grace and our community partners in public health have done over the last year and a half. But public health is about population health. And a lot of that work is really proactive. It's about education. It's about informing people how they can live their best, healthiest lives. And that work requires ongoing outreach. And so as somebody who's spent a good deal of time working in public health over the last 10 years, I really see the value in using these dollars this way. I certainly respect your observation about process, and I think those concerns are well placed, and we do need to have those conversations both with our community partners and with the Budget Advisory Committee. But I think there's a clear and compelling need for this position. So I personally, while I'm not a policymaker, I really support this request.
Thank you. I appreciate your input. I just know that as a commissioner, there are 2 other requests that are going to be coming before us for increases. And I think those have merit also. So as a commissioner that has to look at all the areas requesting money, I have to determine which one am I going to support? Because guess what? I can't support all of them. So this is where I'm having a struggle. I do not disagree that, you know, public health is important and this is a good use of some funds, but I have to weigh what do I think is a priority in this budget? And I'm not there yet because I kind of want to work through the process. So Commissioner Swallowson.
Yeah, thank you, Madam Chair. And I'm actually aligned with where you're at. I think the discussion, it certainly has merit. I certainly support, and I am certainly grateful for all of the work that's been done. And I think it is certainly a strong candidate, but I would like to have the broader discussion as well. I saw 2 other items that were actually out for our approval today. One of those was for a request to add an additional $2 an hour onto the home health care portion. And then there was a request to extend the current temporary one through the end of the month. If you want to move to those discussions, however you want to handle it, it's up to you. But I actually saw 3 items that we were needing to discuss.
If I may, Commissioner Swelson, a point of clarification regarding the $2 increase. That was intended as a heads up for what will be coming in our 2022 department budget. So introducing that as a proposal that will be forthcoming in August on the 8th when we present our draft budget.
Very good. Thank you. Thank you, Allison. That's appreciated.
Any other comments or questions? Commissioner Sullivan.
Thank you, Chairperson Hawkins. I just wanted to suggest that I do support the request for the health educator, and I'm looking at the intention behind the American Rescue Plan. I also think it is so important that we are proactive and that we try to educate our population here in Cook County. So I just wanted to share that.
Thank you. Commissioner Starley, I saw your hand first. I'm sorry.
So the word timing is coming out to me. Is there a timing on this, or could we wait a month just to see what kind of, back support you would get for the hire of a public health educator?
So with the approval of the contract extension under our consent agenda item, that does give us a bit more time in terms of the immediate impact and on our existing public health staff. So if we were to bring a proposal before you at our July meeting, that would give us a very short turnaround to be able to post for and hire that position. But again, we're looking at August 1, a loss of 40 hours to our public health unit, which would have a significant impact on the current 2 staff to either take on the work that's being provided by our temporary staff or scale back.
Commissioner Mills.
Thank you, Madam Chair. And I had almost the exact question as Commissioner Storley, just looking at our options here and noting the extension of the temporary. We could very well do another extension of the temporary, right? Or no, we cannot. I'll take that.
Not be
Okay.
able to, as that would be going beyond a year of temporary.
Thank you very much for, yeah. Okay. that was, I guess that's my question for now.
Andrea, I saw your hand up. Did you have a question or a comment?
Yeah, I was just gonna say that if we put this out a month, that would leave a really small turnaround time to hire. I mean, you know, some county jobs stay open for a long time because you have to have somebody qualified. First of all, you have to get through that process that you know, the state application website. So I think that, you know, it would be really, I think it, since I collaborate with Grace a lot, I think it would be really hard to go even a week without that extra 40 hours of public health staffing. So putting it off for a month doesn't really give, you know, a lot of time to fill a position that has specific qualifications. That was all I was going to say. And I support it.
Roger, go ahead.
I think the last comment I'm going to make is that everybody sitting in this meeting knows there is no perfect time to make a decision like this. And I would hate to see us cut short when we may need somebody come August. We don't know. I mean, I certainly understand, Madam Chair and Commissioner Swallowson, Commissioner Storley, where you're coming from. But I just don't know if there's a perfect time to make the decision. I'm not sure it's one we can put off. So that's my 2 cents.
Thank you. Commissioner Mills.
Thank you, Madam Chair. And yeah, I was just listening to discussion and rolling things around in my mind, and I, you know, I want to respect the process that we're going to be using for the American Rescue Plan dollars, but I guess in my mind, the number one priority right now is public health, and that is I think the number one intention of the American Rescue Plan dollars, although it does allow for other uses. And again, in my mind, and I think we're all on similar pages with this, the housing issue is another big one, and that's a pretty clear cut, can be used for infrastructure stuff. But so yeah, it's a little bit of a juggling act here with, and ultimately us as a board will be determining or approving those American Rescue Plan expenditures. And so weighing all that, I do think this is probably the most appropriate use right now, and the timing is not ideal because it kind of shakes our process up a little bit, but I think the need is clear, and funding right now is clear for that, and so I just want to do what we can to support our community and continue to support our staff and public health there, because it's been pretty clearly demonstrated that there has been continued cuts statewide with it, and there's been a continued increase in need of public health. So it's just weighing all that. It's not easy, but I feel like I'm in full support at this point.
Thank you for sharing. Anybody else have any comments or questions? Well, I'm still, we'll just share one last time. I still have some reservations, and I question if this is the right time for this. So I'll just lay that there. So we're on to action then. What do we want to do? Commissioner Sullivan.
Chairperson Hawkins, I'd like to move to approve to hire a full-time public health educator.
I'll second. This is Andrea.
We have a motion and a second. Any further discussion? Seeing none, hearing none. I will do a roll call vote. Commissioner Sullivan,
Aye.
Commissioner Swallison,
Hey,
Mr. Linehan,
Aye.
Commissioner Storley,
Nay.
Ms. Orest,
Aye.
Commissioner Mills,
Aye.
Commissioner Hawkins is a nay. Motion passes. Okay, we will move on to item B, which is approve the subcontract for the public health education and response. Allison, do you want to introduce that, or Grace? I don't know which one wants to talk about that.
Sure. So this is a proposed subcontract with the clinic to make whole the SHIP position funded with funds that are received through our community health board to support some of that policy systems and environmental change work that's happening in our community. And the proposal would be to make that position full-time using either county funds, grant funds that we would secure through state or federal resources, including the American Rescue Plan funds as a potential revenue source to support this position.
Thank you. Any questions or comments? Commissioner Mills.
And so again, a little bit of process juggling here, but I did, I also want to point out that in the absence of the American Rescue Plan dollars, that it would be coming from the help me with words, am I even on the right? Oh, I'm sorry. Yes, thank you. And I was clicking on the wrong link here, but yes, that 15,000 would come from the fund balance of Public Health and Human Services. So I think it's again a juggling of the process, but statewide health improvement plan, I think, is something that it's still not clear what's going to be happening there at the state level this upcoming year, and so I want to make sure that we can support it as much as possible as a county. Seems a little shaky, and I think again the benefits of this program have proven year after year to be so beneficial for our community.
Thank you, Commissioner. So just to clarify, this request is to fund the increase in the position through the end of this year, and then we would present a scenario for your consideration for the 2022 department budget in August.
Thank you. Clarify there.
Anybody else have any comments or questions? And I'll just share that this is one that I really didn't have a problem with. I thought, okay, we have an end date. It's going to be reevaluated. I know that Andrea's done some awesome work under this program. But because it had an end date and then it was going to be reevaluated, and I understand it was pandemic and there's lots of things going on. So this is one that I didn't have quite as much problem with, but now that we've hired another full-time nursing or public health position, I'm wondering, is this needed? We got a full-time one now. So can you just speak to that for me, please?
So there are a lot of moving parts as to how the duties would be allocated across our internal staff positions and our subcontracted programs with the clinic. But some of the deliverables defined in the draft agreement that was brought before you this morning include work that is already happening within the SHIP program led by our SHIP coordinator, but really looking at the opportunity to expand and address additional unmet needs that have been amplified or will continue long beyond the effects of the health effects of the pandemic in our community. So those include assessing and addressing local food security needs. We had the good fortune of working with Elsa Lundy last year as an AmeriCorps service member, and she did a lot of research and work with partner agencies on food insecurity. Again, this is one of our health priorities, is defined by our community health assessment. So how can we best support people who are experiencing food insecurity and economic insecurity because of the continued impacts of the pandemic? And back to Grace's earlier point during our presentation about continued engagement with our Minnesota Response volunteers. That would be another area where Andrea and her role and how she's been able to shift over the last year from some of that policy systems and environmental work towards emergency response, being able to support that continuing on to really engage and support our large pool of volunteers who have contributed so much over the last year. And then that ongoing technical assistance to businesses and event planners, as well as a really key priority and deliverable for increasing this position. Anything else, Grace, that you would add to that?
I think you covered it pretty well, the three areas that so SHIP, generally speaking, focuses on active living, healthy eating initiatives. And then with the pandemic has also shifted quite a bit of its work towards the technical assistance to businesses around infection control, as well as volunteer management. So in the area of response and recovery, it would be continuing to support Minnesota Response volunteers in response to requests for technical assistance relating to infection control for businesses and events in the community. In the healthy eating area, it really is responding to an increased measure of food insecurity because of the pandemic and some of the disruptions to business and employment for our community members. So that would be the focus of making the position whole through 2021. Very discrete elements of response and recovery that do align with the current work being done in SHIP.
Commissioner Mills.
I just wanted to add that the feedback I've received from the business community, and I've been sitting on this pandemic economy group, has been very, very positive and very grateful for the work being done with the SHIP coordinator position. And I think it's largely recognized in the business community that we're not quite out of this yet, and that continued support is much appreciated and much needed. But things are, of course, improving very quickly, but in the meanwhile, as we have more events and more visitors, I think that part is important, and hopefully more food distribution events as well. But I know the AEOA side of things, I think they had their last one, but we do need more of that support. And I have also heard community comment just about particularly the food scarcity issue.
Anybody else have any comments? Okay. No more discussion or questions? Oh, I'm sorry. Roger, did you have your hand up and I didn't see? Oh.
No, I just couldn't hear you there for a moment.
Oh. Again, well, I look at my agenda that's over here. I'm sorry. So I'm wondering, do we have anybody who wants to take action on this item?
Madam Chair, I'll make a motion to approve.
Thank you, Commissioner Mills. We have a motion. Do we have a second?
I will second.
Commissioner Swallowson, thank you. Okay. Any further discussion? If not, I will take a roll call. Let's see. Commissioner Mills.
Aye.
Zorist.
I have to abstain as a Sawtooth Mountain Clinic employee.
Thank you. Commissioner Storley.
I'm going to say aye with a preface that we'll have a chance to review this at, another time, but it's not that I'm black and white, yes or no. There's just a lot of things that we have to consider as commissioners, so I will support this.
Mr. Linehan,
Aye.
Commissioner Swallowson,
Aye.
Commissioner Sullivan,
Aye.
Commissioner Hawkins is also a reserved aye. Yes, thank you. That passes. All right. I apologize again. I cannot judge time on how many questions and information we're receiving, but I'll work on that. And so I'm going to suggest that we move our committee reports to next month, and we move to adjournment if we have a motion to adjourn. Oh, sorry, Administrator Yorkie.
Yes, Madam Chair, thank you. Just for your information, I've gone ahead and taken the liberty of moving future committee of the whole meetings to 10:30, so that we'll have a full 2 hours for future agendas.
Thank you. There's so much to learn here. It's going to take a while.
Absolutely.
So thank you for that.
Motion
Okay.
to adjourn.
Thank you, Commissioner Mills. Second.
And Swallowson seconds.
Good. Thank you, Commissioner Mills. Discussion? No. I'll do the roll call. Commissioner Mills,
Aye.
Commissioner Swallowson,
Aye.
Ms. Orist,
Aye.
Mr. Linehan,
Aye.
Commissioner Storley,
Aye.
Commissioner Sullivan,
Aye.
and Commissioner Hawkins says aye. Thank you all so very, very much. I will see you in a couple of minutes. You're going to give us a few minutes break though, right? Thank you.
We can't start without you.
Thank you so much.